медицинского мнения. Для этого пациент отправляет нам свои медицинские заключения, лабораторные исследования, если есть радиологические снимки. Специалисты клиники ЛИВ рассматривают и составляют план лечения и диагностики. Алгоритм требующихся обследований, а также их предварительная стоимость отправляется вам на почту. После того, как вы подтверждаете план диагностики и отправляете нам дату вашего приезда, мы организовываем вашу предварительную программу обследования. В случае надобности помогаем вам с резервацией отеля. Также предоставляем вам трансфер с аэропорта в аэропорт. Передаем всю вашу медицинскую информацию, отправленную вами, русскоговорящему переводчику, который будет вас сопровождать в период вашего пребывания в клинике. В день вашего приезда наши коллеги по логистике встречают вас в аэропорту и привозят в клинику ЛИВ. Сейчас вместе с вами посмотрим продолжение. Мы, как клиника ЛИВ, гордимся тем, что нам предоставилась честь узнать вас. Отныне мы являемся частью вашей семьи и готовы вам помочь круглосуточно касательно вопросов вашего здоровья. Международный отдел клиники ЛИВ желает вам благополучных дней.
Live Hospital, which promises to be the future of healthcare with its experienced patient care and guest-oriented approach, opened in Vadistan. It is that moment which makes you hold on to life, sometimes near a forest, sometimes in daily life. With its advanced diagnostic and treatment methods, that moment actually represents the future. There are some moments which makes you look to the future confidently. Those moments are the future. Live Hospital, the future of healthcare, opened in Vadi, Istanbul.
В Вади, Истанбул, открылась больница будущего Live Hospital, отличающаяся опытом в уходе за пациентами и гостеприимным подходом к своим пациентам. Порой расположение на краю леса, порой в жизни наступит момент, когда продвинутые методы диагностики и лечения помогут вам выжить. Этот момент обязательно настанет. Есть моменты, когда вы начинаете смотреть в будущее с уверенностью. Так вот, это именно этот момент будущего. В Вади, Истанбул, открылась больница будущего Live Hospital.
Merhaba, ben Profesör Doktor Levhi Akın. 2014 yılından beri Liv Hospital Ulus'tayım. Genel cerrahi ve cerrahi onkoloji uzmanıyım. Aynı zamanda tıbbi yürütme kurulu
Now, I want to say good morning to everybody. We are at Liv Hospital Vadi, Vadi Istanbul now. Me and my colleagues are going to present colorectal cancer systemic management of metastatic disease, especially for liver metastasis. Now, with me, I have three colleagues. One of them is our surgical oncologist, Dr. Professor Koray Karabulut. He is going to mention about surgical treatment of metastasis. And then Professor of Radiology, Adem Uçar. He's going to mention about interventional radiological methods. And lastly, my other colleague, Dr. Associate Professor Emre Sivrikoz, will mention about primary tumor management in metastatic colorectal cancers. And me, as medical oncologist, I would like to introduce you to colorectal cancer, and I'm going to mention about all systemic therapies. Now, I want to share my screen with you. I hope everybody is seeing it as full screen. Now, I will talk about the systemic therapy in liver metastasis of colorectal cancer disease. As you know, colorectal cancer is the most third commonest cancer in all around the world with a percentage of 10. And as we look at the number of deaths in both sexes, we can say that it is the second most common cancer-related death. And colorectal cancer in United States, we see 1,050 new cases in 2021. And 1/3 of these deaths were due to colorectal cancer. And the incidence and mortality rates have decreased significantly during the past 30 years, especially in individuals who are 50 years of age and older. But however, the incidence rate for colorectal cancer in men and women who are below 50 years of age, the disease has risen by 2% each year. I mean that these colorectal cancer cases are more common now and rising in younger patients, and they are diagnosed in a more advanced stage disease. What is the reason for this? Diet and obesity seem to be possible causes of this. We don't know the exact percentage of it. Sorry, I think there is a problem with the, okay. Now I think you cannot see my full screen. I'm just trying to do it again for you. Now.
It's okay for now, dear
Okay.
doctor. Thank you. Yes.
Okay, now I'm happy. Now we know that in colorectal cancer, there's a tumor heterogeneity. What is this heterogeneity? It is a whole disease with different kinds of mutations. The RAS mutations are the most important ones. KRAS and ARAS mutations are common. And also BRAF mutation is important. Microsatellite instability is important, and we sometimes choose therapy according to these mutations. And what are our treatment goals in metastatic colorectal cancer? Our one important goal is to enable resectability of an unresectable tumor and to cure the disease, to extend survival, to give all therapies with less toxicity, and to manage side effects effectively, and also to preserve the quality of life of the patient. And intensive therapies are most effective at the beginning. So if we want a good response, we should give the best treatment, best systemic treatment in the first line, because overall response rates and survival rates are higher with the intensive therapies. In metastatic colorectal cancer, we have increasing number of treatments. As you see here, chemotherapy, anti-VEGF agents, the most common is bevacizumab, anti-EGFR agents, panitumumab and cetuximab, and also we are using now immunotherapies and other targeted therapies such as anti-HER2 therapies. What happened with these new treatments? The survival of the patients are now better with these different lines of treatments. It was approximately 12 months before when we were only using chemotherapy, but after these new therapies, now it reaches 3 to 5 years in these patients. And all we know that tumor location is also prognostic for survival. So if we are trying to do the best resectability, we should be aware that the patient should have a left-sided tumor, because right-sided tumors have worse prognosis than the left ones. And also, longer overall survival is seen in patients with RAS wild-type disease. If the patient has a RAS mutant disease, we know that it is this patient will have a worse prognosis. We see better prognosis with RAS wild-type patients, and here we see all phase 3 studies and the use of bevacizumab and cetuximab, anti-VEGF and anti-EGFR agents together. Now, just look at the survival rates. The survival is extending. It is reaching up to 4 or 5 years with all these treatments. And especially, there is an impact of sidedness for RAS wild-type patients. We know that the left-sided tumors give better response to therapies with anti-EGFR agents. And for right-sided tumors, bevacizumab, anti-VEGF targeted therapies are better for the patients. So let's come to the metastatic disease, resectable colorectal cancer, liver metastasis. Hepatic metastatic disease is a very significant problem for us. There are some regional treatment approaches. We will talk about them today, and also systemic therapies with this. But we should always be aware that surgery remains the gold standard, because it is associated with long-term relapse-free survival plateau. If the patient is resectable, we should resect it, because it is the best option for the patient. And before 5 years, we were saying that the patients should have 3 lesions in the same node, maximum 3 lesions, and we should achieve 1 centimeter margins, and we should do surgery to only without portal lymph node metastasis. But these rules have been changed now. We are trying to do our best for our patients, and we are talking about the patients in our tumor board, and we decide together, because surgery is the mainstay of the treatment of hepatic metastatic disease. And for low-risk patients, for example, if the patient is medically fit, has 4 or fewer lesions, has metachronous disease, we see metastasis afterwards. And if the liver is the only site of metastasis, we should choose surgery rather than neoadjuvant chemotherapy. But for patients who have higher risk, who has a borderline resectable disease or unresectable disease, but may be resectable, neoadjuvant chemotherapy is the preferred approach for these patients. And we should always check the patients with radiologic assessment at 6 to 8 weeks intervals, because the longer we give the chemotherapeutic agents, the longer we give the biologics, the side effects of the therapy are coming to us, and it may be impossible for the patient to have the surgery. And if the patient is using bevacizumab anti-VEGF targeted therapy, the surgery should be delayed at least 4 weeks after the completion of chemotherapy. 6 to 8 weeks is better. And now we have another option. We say that chemotherapy-related liver toxicity is important for the surgeon. They always ask to us, because we are using oxaliplatin-based chemotherapies and irinotecan-based therapies. Both of these agents has hepatotoxicity, different types of hepatotoxicities. For example, for irinotecan, we see steatosis and steatohepatitis in the liver. For oxaliplatin, we see non-cirrhotic portal hypertension, sometimes vascular changes, and this may increase the mortality of the patient after surgery. So the lesser is the better for the surgeon. We should evaluate the patients frequently. For example, if we use a bevacizumab-containing regimen, we know that after the surgery, the patient has some risks such as stroke, such as arterial thromboembolic events, such as bowel perforation and bleeding. These are all 2%, but if the patient has these side effects, it can be mortal for the patient. And the longer half-life of the bevacizumab makes us to be careful, because we should wait approximately 6 to 8 weeks, but at least 5 weeks should be waited for the resection of the patient. And if the patient is initially resectable, what can we choose? Will we choose surgery, or can we choose initial systemic therapy? It depends on the patient, but if it can be resected, we ask our surgeon in our tumor boards, we send the patients to the surgeon. But for patients with a good performance score, performance status, who have more than 4 metastatic disease, unless all are localized to a single lobe, and radiographic suspicion for portal node involvement or bilobed disease, sometimes we try to do surgery for these patients, but if tumor involves any segments of the left and right liver, initial systemic chemotherapy should be started at first. And at some other centers, they give 2 or 3 cycles of preoperative chemotherapy for potentially resectable liver metastatic disease. This can depend on the hospital, and it can depend on the doctor opinion. So we discuss our patients in tumor boards. And there is a trial, EOTC trial, which supports immediate resection rather than upfront chemotherapy. This was a study which was done at 300 and more patients with up to 4 metastases, and the patients were randomly assigned to liver resection with or without FOLFOX chemotherapy. And as we check for the results of this study, there was a non-statistically significant trend in 5-year progression-free survival, which favors the chemotherapy group. It is a non-statistical significance, and 5-year overall survival rates was not significantly better than the chemotherapy group. So we may do surgery at first in these patients. But there are some important issues to be considered for the right therapy for initially resectable metastatic disease, such as poor tumor biology. For example, if the patient has BRAF mutant disease or RAS mutant disease, maybe neoadjuvant chemotherapy should be better at first. because these patients can go with worse outcomes. And if the patient has comorbidities, this is also important. There are some prognostic guidelines for the hepatic liver metastatic disease. And according to this prognostic index, we try to do our best for the patient, which will be the first therapy. We discuss the patient. And are the tumors resectable at present, but just a minor response would make the operation significantly less difficult. And this will allow the surgeon to more easily achieve a margin-free resection. Maybe we may start with chemotherapy then. And if the patient completed adjuvant FOLFOX chemotherapy previously, how long ago was it? These are important for us, and especially mutations are important for the treatment of patients. Okay, now we are going to talk about systemic chemotherapy with or without cetuximab in patients with resectable colorectal liver metastases. This is a mid-epoch trial, which is a phase 3 trial. If the patient has resectable metastasis, cetuximab is not offered because the results of the study is not favoring the use of cetuximab for resectable disease. And what is NCCN says about this? If the patient is resectable, then resection should be done at first, or you can also start with neoadjuvant therapy for 2 or 3 months, FOLFOX, CAPEOX, or FOLFIRI, and then colectomy could be done. Or you can do colectomy at first, and then you give chemotherapy to the patient. So NCCN also favors the use of chemotherapy when needed for these kinds of patients. What about initially unresectable or borderline resectable metastasis? We know that if the patient is truly unresectable at the beginning, only 10 to 15% of the patients are resectable, and pathologic complete response rates are also low. But the term conversion therapy is used. We may help the surgeon to make an unresectable disease to be resectable. So this should also permit the surgeon for R0 resection. But 5-year survival rates average approximately 30 to 35%. And these results are substantially better than expected using chemotherapy alone. And the majority of radiographic completely responding lesions contain viable tumor. So although you have a complete response, you may do the surgery because you can think everything has gone, but when you look at the pathology report, you will still see viable tumors. This is important for colorectal cancers. Which regimens do we use? We use FOLFOX, FOLFIRI, or FOLFOXIRI. For RAS mutant disease, we may use bevacizumab-based, anti-VEGF-based chemotherapies. And if we want a very good response, we may use triplet regimen rather than a doublet regimen. And if the patient is not right-sided and RAS wild-type disease, then we may use FOLFIRI plus either cetuximab or panitumumab. And regardless of the regimen that is used, the number of perioperative cycles should be limited to 4 because of the potential for liver toxicity. This is an important issue for the surgeon. And the benefit from the addition of a biologic agent is controversial. In some studies, in phase 2 SELEM trial and also phase 3 trials of CRYSTAL and OPUS, it shows modestly improved resection rates from, for example, 4 to 7% and from 2 to 5% respectively, with the addition of cetuximab to a chemotherapy regimen. So the benefit from the addition of a biologic agent may be very small. We should be very careful when we add a biologic agent. For example, if the patient has a right-sided colon tumor, right colon tumors derive no benefit from anti-EGFR antibodies for initial therapy, even if they are RAS wild type. Thus, we would only choose an anti-EGFR agent for patients with a left-sided primary tumor. But however, based on the new epoch data, we also be careful when putting cetuximab to the chemotherapy. But of course, the addition of a biologic agent sometimes helps the surgeon to make the surgery better. And the addition of beva was associated with higher rates of objective responses and overall survival and median PFS rates, and also the resection rates may be good with it. And what does NCCN say about this? It says that when the patient has an unresectable synchron liver or lung metastatic disease, systemic therapy should be started with anti-VEGF, or if the tumor is a wild type, a RAS and BRAF wild type, you may add an anti-EGFR agent to the patient. And if the metastatic disease is metachronous, it is important that if the patient has previously taken adjuvant chemotherapy with FOLFOX or CAPEOX within the past 12 months, then you may use chemotherapy with VEGF, or if the patient has wild-type disease, you may also use chemotherapy with anti-EGFR therapies. But if the patient didn't take within the 12 months therapy with FOLFOX or CAPEOX, you may start with every systemic therapeutic options. I would like to mention about one or two more studies to you, which is important for us. In liver-limited disease, PRIME study, which is a panitumumab combination study, panitumumab plus FOLFOX and FOLFOX chemotherapies, we can see that early tumor shrinkage and response rates are better with the combination group, although the p-values are not statistically significant. But for wild-type RAS disease, any resection and complete resection rates may be higher with the addition of panitumumab. As we see here, median PFS values are better with the combination, and overall survival is also numerically higher for these patients. And another trial last year in ASCO showed us that this is a phase 2 WOLFI trial. Do we need to use a triplet regimen with an anti-EGFR, or a triplet regimen only for resectability? This trial showed us that overall response rates are higher with the addition of panitumumab to triplet regimen. Resection rates are different in this study. And here we also see the overall survival curves. And this 4-drug regimen may represent a valuable treatment option in fit patients with high tumor load and chance of secondary resection of metastasis. And this was an important study for us, although it is a phase 2 study. Another phase 2 study with triplet regimen plus cetuximab versus triplet plus bevacizumab, which shows us that the deeper the response, it is better with cetuximab arm for RAS wild type tumors. So the depth of the response is also important for us. So triplet regimen may give you a better response, especially for RAS wild type disease. You may add an anti-EGFR patient to the patient's regimen. And we have seen that RAS wild type and RAS mutant disease is different. What about BRAF metastatic disease? BRAF metastatic disease, we know that has worse prognosis. And it is better to start with an triplet regimen plus anti-VEGF agent. In the studies of BRAF mutant disease, such as FIRE study, we have seen that which compared two arms, the triplet regimen FOLFOXIRI plus cetuximab, and the other arm is triplet regimen plus bevacizumab. We have seen that progression-free survival favors bevacizumab use for these kinds of patients. Longer PFS is seen with the addition of the VEGF agent. Now I'm going to my last slide. The second important disease is microsatellite instable disease. If the patient has MSI high metastatic colorectal cancer, we have seen with these studies that pembrolizumab or nivo plus ipilimumab may give good responses. And Keynote 177 trial was the best trial for this. For metastatic colorectal cancer patients with MSI high disease, we have seen that immunotherapy is better than chemotherapy. And also for Nivo plus EP, it was the same. But we should be aware that there is still 18% of fast progressors with the combo. So what do we prefer for MSI high disease? We may say that we still use chemotherapy for this disease because 20% of the patients may be fast progressors. Maybe we will have a new prospective study which compares addition of pembrolizumab to chemotherapy. It may be better for these kinds of patients, but we have only limited data, so we are still using chemotherapy for the chance of resectability for these kinds of MSI high patients. And HER2 is another biomarker for metastatic colorectal disease. We use different combinations of anti-HER2 drugs together, but we still don't know that if the patient has HER2 positive disease, at the beginning, which regimen should we start with? We should also start with the best chemotherapy regimen. So this is the summary of my slides. Choice of the best first-line metastatic colorectal cancer treatment with patients with clearly metastasis, resectable metastasis, we may use surgery alone or surgery with peri or postoperative chemotherapy. And if our goal is tumor shrinkage, early tumor shrinkage and cytoreduction, we use RAS wild type disease for RAS wild type disease. If it is left-sided, we add anti-EGFR to the chemotherapy doublet regimen, FOLFOX plus anti-EGFR or FOLFIRI plus anti-EGFR. But if it is right-sided, we should add bevacizumab because we have seen that anti-VEGF agents are better for right-sided tumors. And also, if our goal is the tumor shrinkage, we may use triplet regimen. If the patient has RAS mutant disease, combination chemotherapy plus bevacizumab is used. And if BRAF mutant disease, you may use the triplet regimen with anti-VEGF agents. These are important. And choice of best systemic treatment in 2022 is summarized here. We should know that the patient has right or left tumor-sided tumors, and we should also know the mutations of the patients. And although it is a right-sided tumor, if our goal is cytoreduction, if our goal is tumor shrinkage, we may use anti-EGFR agents here. And also, there is a highest unmet need for these kinds of patients for right-sided tumors. And there are other studies. My colleagues will tell us about these studies. There's a new approach trial, which combines the other therapeutic options, such as radioembolization with chemotherapy. If the patient doesn't give good response to first-line chemotherapy, you may use radioembolization with chemotherapy for these kinds of patients because the PFS and hepatic PFS are better with this combination. Also, tumor responses are better with these combinations. And here is the summary of my slides. For first-line therapy, then we use which chemotherapy. For second line and for third line are also summarized here. I just put this slide here because this year ESMO, the colorectal cancer oncologists told us that always you should consider 4 R's. Resection, always you should consider. Re-challenge, you should consider. Reintroduction, and radio and ablative therapies. And now here, both of my colleagues, we are a team working here at Liv Hospital. Resection and radioablative therapies are always in our mind for the treatment of colorectal cancer patients. And here is the future of the colorectal cancer treatment. We should check for the mutations. Tumor localization is important for therapy selection. New biomarkers are coming, liquid biopsies are coming, and in future, maybe we will treat patients according to CMS subtypes of the patients. I want to thank you to all of you for listening to me. Here they say, I need courage, I need a heart, I need a brain. I'm over 50, I need a colorectal exam. I want to thank you very much. for listening to me. Now, I think my other colleague is going to give his lecture to you. The Koray Karabulut professor, he is the surgical oncologist of our hospital, and he's a good gastrointestinal colorectal surgeon. Now he's going to mention about the resection of metastatic disease. My colleague, Dr. Koray Karabulut.
Hello, thank you for your nice presentation, Dr. Çiğdem. I want to share my slides. Sorry. Okay. I'm going to talk about the surgical management of colorectal cancer liver mets. As you know, more than 50% of patients will develop liver mets during their treatment course, and overall 5-year survival without liver resection is about 10%, but it is possible to obtain 5-year overall survival more than 50% of these patients using multimodality treatment modalities, and these high survival rates are even for bilobar complex colorectal mets. The treatment, multidisciplinary planning and treatment is essential, and the team should include medical oncology, radiation oncology, for radiosurgery or stereotactic radiotherapy. Radiology is important for both diagnosis and for interventional procedures, ablation procedures, transarterial treatments. Nuclear medicine, pathology, genetics are important, and also general surgery, HPV surgery is essential, mandatory for this multidisciplinary team. So we know that surgery is the most effective treatment modality to obtain best oncological results. But for surgery, the primary tumor and all liver and extrahepatic metastases can be removed as R0. For planning of the surgery, we have to consider 3 main parameters: the patient, the tumor, and the liver. For the patient, the general condition of the patient is important. Age, comorbidities are important because we are performing our procedures under general anesthesia. So they should be fit for these surgeries. The other important point is oncological evaluation. The tumor, we are evaluating the tumor using both ultrasonography and cross-sectional image, CT, MRI, and PET-CT. We are evaluating the number of the tumors, mets, the diameter of them, location, uni or bilobar mets, the relationship between the vascular structures and biliary structures, and we are trying to understand if there is an extrahepatic tumor mets or not. These are important points to decide the oncological resectability of the tumor. And to understand investigate the extrahepatic disease, PET-CT is an important modality in selected patients. And the third parameter is liver. We have to also evaluate the liver using imaging modalities, ultrasonography, CT, and MRI. We are trying to see the fat content of the liver, the steatosis, if the liver has any damage due to any chronic liver disease. These patients generally take some preoperative hepatotoxic chemotherapies. It's also an important parameter to decide the extension of the resection and the volume after resection. Future liver remnant is also important to decide the technical resectability of the tumor. We know that these metastatic, the chemotherapy treatment options can give some damage, hepatotoxicities to liver. One of the well-known medication is oxaliplatin. You can see a healthy liver in this slide, and in this video you can see a patient, one of our patients who received chemotherapy for a long time period, and you can see that the fatty content of the liver. So it's a good example to see the macroscopic appearance of a chemotherapy damaged liver. This is another example. So for these patients, the functional capacity of the liver is always less than the volume of the liver. So the future liver remnants should be more than a healthy liver's future liver remnant. So after patients have met physiological and oncological resectability criteria, the ability to surgical resection of all metastases with negative microscopic margins while leaving an adequate future liver remnant must be critically assessed. So the aim is obtaining R0 resection, tumor-free resection margins, and an adequate future liver remnant. For safe resection, the volume and functional capacity should be adequate, because the volume is not always equal with functional capacity. Arterial and portal perfusion of the remnant liver is also important. Biliary and venous drainage is also important. Synthesis function is important, and the regeneration capacity is also important to decide the extension of the liver resection. For a healthy liver, 25% future liver remnant is going to be enough. When we make another calculation, the future liver remnant body weight ratio must be more than 0.8% to obtain to prevent the patient liver insufficiency after the resection. If the future liver remnant is not large enough, there is a risk of mortality due to liver insufficiency after resection. So what type of surgeries are we performing? We are performing different type of resections according to the location, number, size of the tumors. So we are performing metastasectomies, wedge resections, segmentectomies, and also some anatomical major hepatectomies like right hepatectomy, left hepatectomy, and extended right and left hepatectomies. And also another option to obtain larger future liver remnant is parenchyma sparing resections, especially using intraoperative ultrasonography guidance. And transplantation is can be a good treatment option for highly selected patients. We can perform these procedures even open, laparoscopic, or robotic ways. This is a case of parenchyma sparing surgery. You can see different multiple mets in different locations of the liver, and you can see the effect of preoperative chemotherapy, a fatty liver. So we have tried to perform a parenchyma sparing resection, non-anatomical resection. And we are trying to obtain tumor-free resection margins. In cases where predicted future liver remnant is inadequate based on liver volumetry, we are trying to use different modalities, different strategies to obtain more larger future liver remnants. So two main options, modalities are in our daily practice. One of them is portal vein embolization. We are sometimes combining this with hepatic vein embolization, bivenous embolization. And the other one is a two-stage surgical procedure, which is named ALPS, associating liver partition and portal vein ligation for staged hepatectomy. They can be used to stimulate hypertrophy of the future liver remnant. We can use portal vein embolization with resection, bivenous embolization, and ALPS procedures, as I said before. In portal vein embolization, we are diverting the portal flow away from the heavy liver to be resected towards the liver remnant, leading the compensatory hyperplasia and of the hepatocytes and organ hypertrophy. Interventional radiologists are performing this procedure generally using ipsilateral site. They are using coil or foam. My colleague is going to give technical details, I think. And hepatic vein embolization may be considered to further optimize the future liver remnant. This is a case of portal vein embolization, preoperative portal vein embolization. After portal vein embolization and 6 weeks after portal vein embolization, we have performed a right hepatectomy and we have resected the solitary met in segment 2-3. So for these procedures, for liver resection, intraoperative ultrasonography is essential to see small unidentified mets to perform the resection, safe resection by evaluating hepatic large vessels, bile ducts, and interventional radiology is also mandatory for ablation, embolization, and for the management of complications. This is another example of a laparoscopic liver resection. This is a non-anatomical resection. I wanted to show this because it is possible to perform this procedure using minimally invasive techniques. This is a solitary met of colorectal cancer in segment 3, and the patient is fit for surgery, and we have decided to perform a non-anatomical segmental resection using laparoscopy. It's a minimally invasive procedure, and the blood loss and the post-operative course is generally more comfortable for the surgeon and for the patient. We are using different tools to obtain good hemostasis and to prevent bile leakage from the transection line. Yeah, I want to show a couple of cases about the procedures that we are using in our daily practice. This is a resection ablation combination case. A young lady with splenic left-sided tumor with synchronous liver mets. She received systemic chemotherapy in another hospital. And 1 year later, they saw enlarged mets and they have performed transarterial radiotherapy. And this is the CT. You can see the large mets at left lobe, segment 4, and the other mets at the right side of the liver. So bilobar disseminated large mets. So this was a young lady, and first we have performed a laparoscopic left hemicolectomy for the primary tumor, and then we have performed left hepatectomy and metastasectomy 1 month after the first primary tumor resection. And also we have performed resection to segment 7-8 lesions, and there was a invasion between the tumor and the diaphragm. So we have performed a partial diaphragm resection. And this is a photo from the operation. You can see the diaphragm on the liver capsule. And after the left hepatectomy, caudate lobe and the transection line, this is the specimen and the pathology. The resection margins were tumor-free. And this is the MRI after resection. We didn't perform a resection to the previous transarterial radiotherapy site because on PET-CT this lesion was ametabolic, and we want to protect the patient from liver insufficiency after resection. But on the control MRI image, we show that there is a segment 6-7 lesion. So we have performed ablation, percutaneous ablation to this lesion. And now the patient is tumor-free for more than 36 months. The second case is an example of an ALPS procedure. The patient had a rectal carcinoma in 2060, adjuvant chemotherapy. After a primary tumor resection, he received adjuvant chemotherapy, and they see a solitary met at the center of the liver. They have performed the laparoscopic ablation in another center, and 3 years after the primary resection, we have performed an ALPS procedure because the left side of the left lobe of the liver was atrophic and the tumor was invading the middle hepatic vein. This is the preoperative CT. You can see the enlarged central lesion invading the left middle hepatic vein, and the left lobe of the liver is really atrophic. So the volume and at the volume analyzed, we after analyzing, we have decided to perform ALPS procedure. It was the first procedure. 10 days after the first stage of the ALPS, you can see the enlarged left lateral section, and then we have removed the right part of the tumor. This was an extended right hepatectomy, and you can see a complication of the surgery, a biloma at the resection site. We have performed the interventional radiologist performed the percutaneous drainage, and the patient is tumor-free. This is the last case, the ALPS procedure. She was a 56-year-old lady. She underwent a laparoscopic low anterior resection for rectal carcinoma in another country. She couldn't finish the adjuvant chemotherapy due to the intolerance to the chemotherapy. And they performed stereotactic radiotherapy for lung mets, and there were multiple liver mets. They performed also radiotherapy for them, and on PET evaluation after stereotactic radiotherapy, they saw 2 newer lesions at segment 7. So they have decided, this is the preoperative CT. You can see the multiple liver mets in both left and right liver. So the left side volume was not enough, so we have decided to perform an ALPS procedure. This is the preoperative PET-CT. This is thorax CT after stereotactic radiotherapy. We have performed a left-sided segment 3 metastasectomy, and we have ligated right portal vein and divide the liver parenchyma at the first stage of ALPS. And this is a photo from during intraoperative photo. As you see, we have removed the segment 3 lesion and divide the liver just right side of the falciform ligament. This is the left lateral side of the patient. So if we perform this extended right hepatectomy, the patient will have a liver insufficiency. So we have decided to go on ALPS procedure. The CT 10 days after, and the volumetric analysis 10 days after the procedure, you can see the right-sided lesions, the fluid around the right part, and enlarged left part of the liver. At volumetric analysis, our radiologists calculated that the volume increase, even metastatectomy of segment 3 in 10 days was 89%. So we thought that we can perform a safe resection with low hepatic liver insufficiency after resection. So we have performed extended right hepatectomy. This is a photo at the first stage. And this CT is after the resection. You can see the enlarged left part of the liver. The resection margins was tumor-free, and this is the pathology report. There were 7 mets at the specimen, more than we expect according to the imaging modalities. So we are following up this patient for more than 43 months. I want to express that liver resection surgery is a teamwork. Radiology, medical oncology, radiation oncology, pathology, genetics. These are important members of a multidisciplinary team. This was my last slide. Thank you for your attention.
Dear doctor, you can start please.
Şu an bende mi Doğukan?
Evet evet hocam başlayabilirsiniz. Yayındasınız şu an.
Hello everyone. I want to present to you radiological interventional methods. I'm going to share my screen. Hello again. I couldn't make screen sharing. I have to overview of the talk without presentation. I tried my best. Surgery is the main potential curative modality for primary and secondary liver cancers. But less than 20% of patients are suitable for resection due to tumor size, location, inadequate hepatic reserve, or presence of extrahepatic metastases. We have a different kind of interventional modality to colorectal liver metastasis: portal vein embolization, tissue ablation methods, and intraarterial interventions. Portal vein embolizations is done to lobar portal vein selectively, tumor-bearing side of the liver. It makes diverting portal blood flow to the other lobe, the future liver remnant. This redistribution induces hypertrophy of the future liver remnant, make it possible to safely undergo major hepatectomy. Contralateral hepatic hypertrophy and ipsilateral atrophy can occur. How we can choose our patients? If it's patient's normal underlying liver and future liver remnant below the 10%, we usually have to do portal vein embolization. And patient who has extensive chemotherapy and portal liver volume below the 30%, or cirrhosis and advanced fibrosis patient has future liver remnant below the 40%, should have go portal vein embolization. Portal vein embolization is minimally invasive procedure. Portal PVA should be done in sterile settings, sterile drape, and it can be done with local anesthesia. We usually reach the ipsilateral approach and percutaneous way. We use ultrasonography to puncture segmental portal vein. We usually use segment 6 and then go to the right portal vein, and then we make portography from the main portal vein. We look for the variation of the portal anatomy, and after that we place the plastic catheter to the right hepatic vein, right portal vein, and we close the first we close the segmentar portal vein with a gel foam sludge or PVA particle, and then place a metallic platinum coils to the right portal vein. We should continue to close all right-sided portal vein branch. Then we should stop. Then we close our puncture site vessels. Then it's done. We usually there is example here. You don't see slide, but there is bilobar disease. Patient have a couple metastases on the right side and single metastasis on the segment 4. We do portal vein embolization, and 4 weeks later, we reach enough enough left lobe volume. At the same time, there is segment 4 metastasis almost double in diameter. Surgeon made a right hepatectomy, and then operation intraoperatively we do microwave ablation at the single metastasis, and patient so far tumor-free in liver. Portal vein embolization intervention made by different technique and different material, a couple different material. We use metallic platinum coils, N-butyl cyanoacrylate, and PVA. After portal vein embolization, almost 4 weeks we wait, and then we do CT or MRI volumetric intravenous examination, and we measure the future remnant liver volume, and we measure the degree of hypertrophy. If it's lower than 5%, it means higher postoperative complication rate. Average increase in future liver remnant volume around 10%. Portal vein embolization is a minimally invasive technique. Its major complication rate around 2.2%. We do tumor ablation methods for curative intent. They are divided to thermal and non-thermal methods. Thermal ablation methods, it can be it can make destruction by heat or cold. RFA, microwave, laser, HIFU, cryoablation, these are thermal ablation methods. And we have non-thermal, ethanol, acetic acid, and electricity may have ablation. RF ablation is the gold standard ablative technique for the tumor ablation. It can be done percutaneously or intraoperatively. RF generator use alternating current, high frequency alternating current. It makes ionic agitation and creates friction in the water molecules. It generates heat and make protein denaturation, and at the end it makes coagulative necrosis. Usually probe heat the tissue around 60 degrees. We should keep in the tissue between 60 to 100 degrees in 5 minutes. Ideal patient for RF ablation up to 5 metastases, up to 3 centimeter diameter, and no vascular or no bile duct proximity. Every ablation should have up to 1 centimeter margin ablation. We usually make RF ablation after control imaging examination. We see bigger than we see the ablation margin bigger than tumor margin. Tumor ablation we do tumor ablation under deep sedation or general anesthesia and ultrasound and CT guidance. There is example here, segment 8 tumor. It's located subcapsularly. It's around a centimeter diameter. We do RF ablation. We do almost 2.5 centimeter ablation zone here. Microwave ablation is very similar to RF ablation. Microwave has two major advantages. Microwave is lower heat sink effect and very rapid ablation times. There's the example here, segment 8, segment 6 lesion. It's very close to hepatic flexura. It's almost 4 centimeter length. Actually, it's little bit higher than normal limit for RF ablation, but patient is old, 89 years old, and patient never get operation. It's personal decision actually. We do RFA. You don't see slide, but we reach almost 5.5 centimeter no contrast enhancing ablation images. After 6 months and 1 year later, MR images here. No enhancing tissue, no recurrence, no residual tissue. Another example here, patient 55 years old man, and he get right hepatectomy for liver metastasis, and patient get one single metastasis in lateral segment. We do microwave ablation, tumor diameter almost a centimeter. We do 2 centimeter ablation zone here. If the metastatic lesion very close to critical structure, we do some kind of dissection technique. We do hydrodissection and air dissection to minimize complication. There is example very close to duodenum segment 2, and it's located posteriorly. We do RF ablation with hydrodissection technique. Then there is 6 months MRI and a year PET imaging. There is no residue and no soft tissue. Also, RF ablation has a lower complication rate. It's around 2.2 major complication rate: bleeding, tumor seeding, bowel perforation. And these are major complications. We have also palliative intraarterial embolization techniques, transarterial embolization, chemoembolization, and transarterial radioembolization. They are palliative technique. It can be bridging to curative surgery or transplantation. Liver has a unique blood supply. Normal liver tissue take blood from the portal vein, almost 80% of the total liver volume debit. But primary and secondary cancers take blood from the hepatic artery, almost 90%. It makes intra-arterial therapy is logical. The goal is blockage of the terminal arterial structure. It's about the 40 micron particles make blockage of the arterial network. It makes ischemia and hypoxia. If we inject intra-arterially any substance, it goes all over the liver homogeneously. If the liver has a one single hypervascular lesion, and we inject a hepatic artery, any substance, it goes almost ninefold of the concentration to the hypervascular tumor. We go to arterial site, femoral or radially. It can be outpatient procedure, but we usually keep our patient one night. It can be done in angiography suite, and it can be done with local anesthesia. Usually keep in mind contrast media allergy and kidney function impairment. Case described by Dr. Yamada in at the end of 70s. Indications of TACE, unresectable liver metastasis, no responses, chemotherapy and disease progression, and toxicity of systemic chemotherapy. If there is a bilobar disease, we should do 2 different sessions, and every single liver lobe we should do 3 different treatments. In the beginning, before the at the 90s, we do conventional chemoembolization. We use lipodiol and chemotherapeutic mixture. Every different interventional center, they use their own mixture. After introduction of the drug-eluting bead, we start to use drug-eluting bead. They are PVA-based beads, and we can load irinotecan. Once on a location, beads release the drug, and sustained and local delivery of the drug. It makes minimize of the systemic exposure. Here's an example, bilobar disease of the colorectal metastasis. It's located big central mass and bilobar around the centimeter metastatic lesions. We do staged chemoembolization. After all procedures, there is CT imaging here, and all metastatic lesions has start to no contrast enhancing. It's like contrast enhancing lesion. Irinotecan for colorectal metastasis. There is a published. There is a paper here, Akin Wande et al. At least 2 prior lines chemotherapy. He says PFS 9 months old and overall survive around 16 months. Contraindications of TACE, poor performance status, higher total bilirubin level, 3 milligram, renal failure, and main portal vein thrombosis. Here is this last intervention of the liver, transarterial radioembolization. It can be done primary or secondary liver tumors. Yttrium 90 microspheres is used. There is 2 different brands, glass or resin microspheres. They produce high energy beta radiation isotope. They are limited tissue penetration, mean 2.5 millimeters. They lodge at an arteriolar level inside the tumor. Almost 97% of the total dose delivered in 2 weeks. Normal liver tissue intolerance of the radiation, especially external radiation. They get radiation-induced liver disease at the 30 grays, but we need higher than 70 grays. These drugs has potential for around 120 grays in tumor dose. It's 2-stage outpatient process. We do in the beginning preparation and mapping stage. And 2 weeks later, we do treatment stage. All patient undergoes a routine preparatory angiography to assess individual hepatic vascular anatomy, to embolize parasitized extrahepatic arteries, and to perform test injection of the technetium 99 to try to determine the hepatopulmonary shunt fraction or extrahepatic activity. Liver arterial anatomy has a number of variation. We should check all hepatic arterial anatomy, left lobe, right lobe, and SMA. Sometimes we should embolize the parasitic vessels. We do MMA scan and dose planning. Lung shunt fraction below the 20%, we should keep the below 20%. No bowel or no stomach activity. Radioembolization has a lower complication rate intervention. It can be has a potential of the survival benefit. There is one example here. Disseminated right lobe metastasis. It's it's bearing almost 70% of the right lobe. We do right lobar radioembolization. This is the 3 months later, PET imaging. We reach the functional imaging here. There is no activity on the liver. Okay, this is my last slide and it's done.
Hello, welcome. We will be continuing the presentation with the primary tumor management in the metastatic colorectal cancer setting. We will briefly discuss, let me share my screen first. I would like to discuss briefly, rather than venturing into the deep aspects of the tumor management, I will continue with what surgical requirements are if you are planning a treatment for the metastasis, what you should look for in the colorectal setting. So I'm Associate Professor Dr. Emre Sivrikos and working as a colorectal surgeon. So we have symptomatic primary colorectal cancers, which are primarily obstruction, bleeding, and perforation. So in these settings, we should be aware to tailor our treatment, which takes precedence. Should we continue with the hepatic resection or oncologic treatment, or should we do something first to the primary tumor? So it is individualized and depends on the presenting symptoms and signs, as well as the extent of the metastatic disease. Perforated tumor needs upfront surgery. There's no question for that. Bleeding or obstruction depends on the actual clinical situation. For the obstruction, we have a couple of opportunities. We can, a couple of options. We can resect. We can divert, we can make a bypass, or we may stent. For an asymptomatic primary, we should aim at a curable metastatic disease. So those who will be resected with an asymptomatic primary who has none of those symptoms that I described just before, in order to resect and gain a positive response from that resection, we should have a curable metastatic disease in terms of the hepatic involvement. And for this potential, we may think to resect the tumor as well to obtain an R0 treatment in the whole patient. Delaying hepatic surgery by 3 to 6 months may reveal the biologic behavior of the metastatic disease, and it may help to select patients for whom hepatic metastasectomy might be curative. And survival rates after resection of colorectal carcinoma, liver metastases, are better in patients who experience an objective response to chemotherapy. So in a setting with curable metastatic disease, simultaneous resection of the primary and metastatic disease is preferred whenever feasible. Or if we are aiming at a staged operation, when we have a disease burden which is higher than, which does not permit a safe simultaneous resection, we should assess the burden of the disease by complexity of the colectomy and also by the size of the future liver remnant and also the likelihood of the major blood loss or prolonged hepatic ischemic times and the patient comorbidities. So therefore, the decision is made case-by-case basis in a multidisciplinary tumor board meeting by taking into account all of these possibilities. And we should look for and try to obtain a complete colonoscopy prior to any surgical resection, given that 45% synchronous colorectal cancers are common, and we have to rule out that we want to make sure that we do not have another primary synchronous cancer lesion than the one that has been detected by, for example, on the CT scan. If the asymptomatic primary is associated with incurable metastatic disease, then primary tumor resection does not offer longer survival. Does deferring surgery increase the risk of emergent presentation with a bowel obstruction, perforation, or bleeding? We should look and see bleeding is 3%, obstruction or perforation may happen in 7 to 14%. NCCN guide suggests that bowel resection may be considered in asymptomatic individuals with unresectable metastatic disease only if there is imminent risk of obstruction or significant bleeding. And this should be discussed in the tumor board as well. So there is a new study, 2021, and this answers the age-long question, is there any survival benefit for upfront resection of the primary colorectal cancer in the metastatic setting? This is from Japan. 165 patients with incurable stage 4 CRC without any symptoms, so asymptomatic primaries. Primary resection was coupled with modern oxaliplatin-containing chemotherapy versus chemotherapy alone. 22 months of follow-up. In the 3-year overall survival, there was no difference noted. Median progression-free survival was also not significantly improved with the resection of the primary tumor. Additionally, there were 3 postoperative deaths among the 81 allocated to primary tumor resection due to postoperative complications. And secondary palliative surgery was only needed in 11, so 13% of the 84 patients randomized to chemotherapy alone. So this is a very select population, and the most important part to consider is they were asymptomatic and truly asymptomatic upfront with the start of the therapy and of the decision of the therapy. So surgical palliation methods are either end colostomy, which is preferred over a loop colostomy, unresectable obstructive cancers, a bypass between the small bowel and the distal colon, distal to the obstruction may be performed. A risk of closed loop obstruction when an intact ileocecal valve is present should be considered in mind. Maybe this procedure may be coupled with stenting. It is again case by case and is based on the location of the tumor. So for non-surgical options, stenting is very popular. However, colonic stenting should not be performed in patients who are or are candidates, who are receiving or are candidates for receiving bevacizumab for metastatic disease. It has been shown that there are significantly increased risk of perforation, and in these patients, we should consider a stoma. In a low-lying rectal cancer, stenting will develop rectal pain and tenesmus secondary to the stent, and in these patients, they are much better served with an end colostomy. and angulating anatomic sites should be best avoided for stents, like the hepatic or splenic flexures, because of this angulation of the stent might cause a perforation in the course of the treatment. So I have 3 cases which we had seen recently. So this is a hugely metastatic rectal cancer. As you see, the burden in the hepatic side. And also there are some distensions in the colon, and the patient is fully obstructed in the rectal area. This is an irresectable primary. We have performed an end colostomy to palliate and make room for systemic chemotherapy available. And the patient is on, I think, more than 6 months under systemic chemotherapy and faring pretty well. So this is a right colon cancer with a huge disease burden, near obstruction, colonoscope cannot be passed, and it has not yet distended, but is metastatic to the liver. In this patient, surgical resection might be preferred due to an imminent risk of obstruction. And in a metastatic splenic flexure cancer, who presented with perforation after 4 months of stenting, which had to be diverted with an ileostomy. And this is the site of the stent in the splenic flexure. As you see, it is angulating. And in this patient, an intestinal bypass might have been considered for palliation, maybe even after stenting procedure, to avoid a ileostomy. So to summarize, if we are considering colon and versus rectum, rectal cancer usually requires multimodality therapy, chemo and radiotherapy, and it will be resected extensively with a diverting ileostomy. And before undergoing this surgical treatment, the patient enough to cope with chemotherapy. And colon cancer is best palliated with resection, if ever possible. If there is overtly extensive disease, and if it's right-sided, it might be best managed with an ileostomy. If it's left-sided in the flexures or at the distal end of the transverse colon, stenting coupled with bypass should be considered. Thank you. If there are any questions.
Thank you, dear doctor, and thank you all participants. Thank you for listening. See you next dedication. Have a good day.
There is a raising hand, maybe.
No, I think.
Okay.
Thank you, dear doctor. See you.
Thank you so much.